Thank you very much, Dr. Janaka Patiraja, for explaining a very broad topic in a very concise way. Really appreciate your effort there. I know it's very difficult to concise it into that short period of time. Quickly moving on to our next plenary. May I introduce Dr. Anupa Herath. The topic would be handling of critically ill cardiac patients. Dr. Anupa Herath is consultant anesthetist at District General Hospital, Trincomalee. Over to you, Anupa.
Right. Good morning, ladies and gentlemen. Very obedient and very polite and calm and quiet audience. Okay, and I would like to thank Sri Lanka College of Cardiology for inviting me for this fantastic academic activity. And I'm hoping that the audience will be much more, if you have any questions, please ask, right? Right. We have been listening to a lot of cardiology and cardiac related lectures. Let's put some critical care. Is that okay? Right. During these 20 minutes, we are going to discuss about how to handle a critically ill cardiac patient or how to identify a deteriorating cardiac patient. And we'll discuss about initiation and giving good quality cardiopulmonary resuscitation, CPR. And we will discuss a little bit about use of equipments, devices, and drugs as well. I have highlighted the cardiac part because when it comes to critical care, when it comes to deteriorating patients, cardiac, not only cardiac, all the systems fail. So I would deliberately take that part off and I'll be discussing patient in general, how to manage a patient who is deteriorating. That is what really important. So let's think about a patient who is about, say, 52 years old lady who had an inferior STEMI 3 days back. In the medical ward, now he's been transferred to your cardiology unit because the patient is a little bit unstable, complaining of ongoing chest pain and shortness of breath, and he's coming with 2 liters of oxygen via nasal prongs. What are you going to do with this patient? So you are the receiving nursing officer, no medics available, no physicians available at the minute. So how are we going to start this patient's monitoring and assessment? Any idea? Where to begin with? Yeah, if you have worked in an orthopedic ward for some time, you will look for cervical spine, long bone fractures. If they are perfect, you are quite happy, isn't it? By the time if you have worked in a labor room or an obstetric unit, you will look for any kind of fetal heart sounds, fetal monitoring, PV bleeding. That is the trend, right? Not only for nursing officers, even for doctors. The place they have worked is what they get biased, so they get distracted by the presentation. It shouldn't be. So whenever we are handling a critically ill patient, we need to have kind of, slides are not moving. Yeah, okay. Whenever we are handling a critically ill patient, we should have standard time-tested method. So that is the method we are using is A to E approach. Anyone has seen, anyone who has not seen this one? I don't think so. It is very simple. It looks very simple, but it is very crucial and very important to follow this approach. Because we have placed airway and breathing at the first, because they are the number one killers. If you miss airway-related, breathing-related problems and attending the other parts leisurely, then you will lose the patient within minutes. And mind you, it is not just an assessment, it comes hand in hand with the intervention. Whenever you find something abnormal in airway or breathing or circulation, you have to intervene then and there. You have to do some interventions and see how the patient improves. And if you see that the patient improves with your interventions, only you move on to the next level. That is very, very important. So what are the things looking in to see in airway? If you talk to the patient, if the patient is talking to you and responding, you don't have to worry about the patency of the airway. Patient can breathe very well. But if they are not talking, if they are making some gurgling noises or abnormal sounds, there may be something lodged. There may be vomiters, secretions, foreign bodies, dentures. You need to suck them out, prop the patient up, keep a pillow under the head and put some oxygen and see how the patient, whether the patient is improving and feeling better. Then put the pulse oximetry. Always check the pulse oximetry before putting oxygen. Then you know what is the saturation on air, and then you can see how the patient improves with your oxygen therapy. If it is not improving, you have to escalate further. Then we move on to the breathing. That is the second part. Check whether the patient is dyspneic, tachypneic. If any patient breathing at a rate of 20 is not normal, there should be a reason, right? For cardiac causes, there may be heart failure, maybe ongoing angina. But for generally, there may be pneumothorax, maybe pulmonary edema, maybe pneumonia, ARDS. We never know the condition, but we are not going to diagnose what is the condition, but we need to detect the abnormality and do something on that. If a patient is about to get exhausted, maybe asthma, maybe COPD, patient may be underlying ischemic heart disease, but these secondary causes, asthma exacerbation, ongoing infection can worsen the condition, right? It goes into a vicious cycle. That's why we are really worried about the breathing. And if the patient is breathing at a high rate, put some NIV, CPAP. Patient will be comfortable. You might order chest X-ray to exclude pulmonary edema, cardiac failure, or even pneumothorax. And then only we move on to the next one. So the third one is circulation. Very basic thing, simple, check the capillary refilling. What is the normal capillary refilling time? 2 seconds, 4 seconds? Yeah, it's 2 seconds. If something beyond 2 seconds, there should be something wrong definitely. Patient is hypovolemic, maybe diarrhea, vomiting, bleeding, everything can cause delay in capillary refilling. It's a simple thing, but very important. Then move on to, you need to get IV access. Always try to put a wide bore cannula. And then giving fluids is very crucial for cardiac patients, as we discussed earlier. So we might have to consider inotropes, diuresis, or even IV fluids that need a little bit of an advanced assessment, but it is very crucial to detect this hypovolemic condition. And some kind of advanced assessment, maybe checking the inferior vena cava level will be necessary, but it takes some time. But you can order the chest X-ray and you can, ECG at this point. And then you can move on to the, so we'll think about our patient. So he comes with nasal prong oxygen, 92 saturation, and making some gurgling voices. Are you happy with that? Gurgling is always some secretions or something. We need to suck them out and then prop the patient up and put some face mask or non-rebreather mask, because nasal prongs 2 liters is not enough for this patient, right? And then think about the circulation, breathing. He's at a rate of 35, dyspneic, and blood gas shows pH of 7.28. Is it normal or acidotic? What do you think? 7.28 is acidotic. And blood gas says carbon dioxide 60. What does it say? Is wash out? Carbon dioxide is being washed out, or what? Retention. And he is hypoxic. This face mask is not enough. We need to move on to at least CPAP. Otherwise, patient will be getting exhausted and go into respiratory failure in the next minute. And how about the heart rate 110, blood pressure 90/50? Not good, right? You have to act promptly. That point we need to consider IV fluid, NORAD, or even diuresis. This needs some physician's attention, but you need to realize and escalate at the necessary level. And the next part, patients are more or less anxious, agitated. They are pulling the lines, putting catheters, trying to get down from the bed. So you always think whether to give some midazolam, whether to give some morphine. It's not the case. They are anxious and agitated maybe because they are hypoxic. If you correct the hypoxia, they will be quite okay. Maybe something simple like distended bladder, you haven't catheterized the patient but giving the diuresis. That may be the cause. Sometimes electrolyte abnormalities, hypoglycemia, hyperglycemia, we have to correct them before just prescribing analgesia or sedation even for cardiac patient, or even for whatever the patient. You have to think what is wrong with the patient. And then what are we going to do with all this assessment? I told you we need to do assessment interventions, and that is very, very crucial to monitor the patient vigilantly. As we have discussed in the previous lectures, you may be having your own monitoring chart, but what I really emphasize is we need to have the trend. If a blood pressure of 110/60 or saturation 94 or temperature 37 doesn't give much information, we need to know the trend. Right? From the beginning, last 10 minutes, during your shift, what has happened to the monitoring chart? Whether the patient is static, improving, or deteriorating. Of course, there are no patients called static, either they are improving or deteriorating. If you think the patient is static but still in hospital, that means the patient is deteriorating, right? That's the way you should take it, and we should need to have real-time monitoring, not to finish your shift because we are busy and just at the end we are just ticking off the monitoring and just before the handing over. It's not the case. We need to see what is happening with the monitoring, and the trend is the one really necessary. So you have a big responsibility to monitor then and there, and real-time monitoring, which gives more information than anything else, right? And with the monitoring, what are we going to do? So anyone have seen this early warning system? I think you may be having your early warning systems in your units. If not, definitely this has to be implemented. Because during the monitoring, we know if all the parameters are within normal range, it gives 0 mark. As far as further they deviate, they get higher marks. If the heart rate is very high, if the heart rate is very low, it goes to red zone, right? Same as temperature, same as oxygen saturation, same as conscious level. Then you can see what are we going to do with this monitoring if the aggregate score, total score, maybe at the end of 1 hour, maybe at the end of your own shift. If it is low risk or aggregate score less than 4, you can keep on monitoring. You can just hand over to your colleague for the next shift. But any patient is giving a score of 7 need to be escalated. These patients has to be seen by critical care team to escalate. That can be either one single reading of any red zone, which anything goes to red zone need to be escalated. So this team need to include with physician and all. So let's move on to our patient. Now, when you are going for the next diuretics or IV antibiotic, the patient is not responding. What could be the reason? He was breathing with face mask, he was okay, but now not responding. Any possibilities? Patient may be sleeping. But most important thing, whether the patient is in cardiac arrest. So how to exclude that? We need to tap on the patient's shoulder, or if you know the name, you can call him loudly, but need a tactile stimulation and see whether the patient is responding. If not, then next thing is we need to check whether the patient is breathing. Any patient who is not breathing, not responding, we consider as cardiac arrest. Right? And then and they are open their way. You can do this look, listen, feel. Look means you can look at the chest, whether the chest is rising with the breathing, and whether you can listen to the breathing sounds, or whether you can feel the expiratory warmth. And if you are really trained and competent, you can check the carotid pulse, but don't take more than 10 seconds for this, because time is muscle, as we discussed earlier. In that case, if the patient is not breathing, patient is not responding, cardiac arrest, immediately call your arrest team. If you're out of hospital, here's suicide. Otherwise, call your arrest team and immediately start chest compression. I think you all have given chest compression. I just need to emphasize the importance of chest compression. You need to keep your non-dominant hand and take the dominant hand, lock it, straight the elbow, and press middle of the lower third of the sternum. Don't press either side, you might break the ribs, right? And just if you can't remember anything, just keep the middle of the sternum and press it at least 4 centimeters, because you need to squeeze the heart to perfuse the brain. And the rate should be at least 100 to 120. It should not be 60 or 70 or something. It has to be very fast, 100 to 120. And allow the chest to recoil. Then only the chest will fill with the blood for the next compression. This is very, very crucial. And if you have ambu bag or support to ventilate, you need to give 2 breaths at every 30 compressions. And immediately, the next most important thing is we need to assess the rhythm, as we discussed in the previous lecture, to bring down the defibrillator. Don't go by the cardiac monitor. There may be, the leads may be displaced, there may be not enough jelly, and it may be over a hairy space. So get your defibrillator and check the rhythm. There can be only 2 possibilities, shockable or non-shockable. So we discussed what is shockable. We know that either VT or VF, right? We discussed in detail in the previous lecture. It can be non-shockable, just pulseless electrical activity. If you see something like electrical activity, it may be pulseless electrical activity, so then there won't be any pulse. If it is asystole, it may be not a straight line, but there may be some fluctuations, but No obvious ECG rhythms are there. Then what are we going to do? Yes, we assess the rhythm as early as possible. If it is shockable, main important thing is to deliver the shock immediately. So first shock we are going to give it 150. Then after the shock, it's very vital you should continue CPR for 2 minutes. Don't check the pulse, don't try to check the blood pressure, saturation, nothing values during cardiac arrest. First shock, 2 minutes continue CPR and then check this rhythm. It's still shockable, go for the second shock. You can escalate the energy for 270. Again 2 minutes uninterrupted CPR, very vital. And then third time, if you have given the third shock, you can start adrenaline 1 in 10,000, 20 ml with a 20 ml flush. And then once you started, you have to continue adrenaline for every other cycle. It's very simple, but most important thing, uninterrupted CPR 2 minutes in between rhythm checks. Very, very crucial. So if it is non-shockable, nothing to be done, right? You give adrenaline 1 in 10,000, 10 ml and flush with 20 ml. Continue 20 minutes CPR every other cycle, adrenaline. So there are 2 minute delay. That means 2 minutes is a fairly long time during CPR. One person or two persons will be giving chest compressions of what the others are doing. There's a team leader, there are your colleagues, there are doctors, and there are a whole lot of team to manage the cardiac arrest. What should they be doing during these 2 minutes? Chatting or just looking at the chest compression? No. The important thing is we have to look for the reversible cause. Patient has gone into a cardiac arrest because of a reason. We have to identify that reason and correct it. Any idea what are the possible causes of reversible causes for cardiac arrest? Any big noise from the back rows? 4Hs and? 4Hs and? Come on guys, 4Hs and 4Ts, yes. There are many possibilities. Out of that, hypoxia is a possibility. Pulmonary edema due to heart failure. It's a possibility. We need to correct that. If you highly suspect that, we need to intubate the patient and ventilate rather than waiting. Hypovolemia, patient may be dehydrated, a lot of diuretics might have gone, maybe bleeding. This is not only for cardiac patient, but if it is hypovolemia, we need to fill the circulation. Otherwise, heart has nothing to pump. That's why it goes into cardiac arrest. Main reason for non-shockable pulseless electrical activity is hypovolemic shock. Then hyperkalemia, especially we know CKD patients, they might have missed the dialysis. Potassium would be 6.57 or it's sky high. We need to correct with calcium and we need to give insulin, dextrose and rest. We have to plan for CRRT or whatever once the patient recovered. Right? And another thing is thrombosis. We are discussing what are the possible options for thrombosis. But this is very important slide. This recovery is a chain of survival. You can see early identification and putting the patient into ICU. We have seen enough patients coming after recovery from cardiac arrest, but their brain is not perfused. Can you see at the last slide, the brain is blue. All the others' brain is ash color because low perfusion. At the end, we need a neurologically intact patient. So the whole strength of the chain depends on the strength of the weakest loop. You understand that? So if one loop is weaker, then the rest of the all three loops are very strengthened, but it doesn't help to the whole strength of the chain. So keep all the loops very, very tidy and strengthened. That's the most important thing, other thing I want to say. Right, then defibrillator, of course, So whenever there's a cardiac arrest, don't go by the overhead cardiac monitor because there may be dislodged and hairy surfaces we can't trust. So get the defibrillator close and apply all these 3 leads wide apart over the chest because we need enough space over the chest to compress and to apply your defibrillator pads. So remove all the leads and apply the 3 leads wide apart on bony prominences. Then you have enough space for your defibrillator pads as well as this chest compression. Otherwise, you will be pressing over the wires. Sometimes with your CPR, the ECG leads getting detached. Next time it was previously VF, now it is asystole. You understand that? So therefore, keep them wide apart. You just need a rhythm strip only. We don't need hi-fi ECG diagnosis just to see whether it is shockable or non-shockable. Apply them wide apart because we don't have hair on these spaces. Then, as soon as your defibrillator is on, you will get that button, right? You need to select the lead 2, right? When it will prompt into a paddle mode, it will always show a normal line. It doesn't show anything if it is in the paddle mode. You need to select lead 2, right? Most of the time you apply, everything is done perfectly, but it is in the paddle mode, it won't show anything. So you need to select it to lead 2. As nurses, always keep the defibrillator pads clean, without jelly and without corroded, and always check your defibrillator every day with that checklist. That is very crucial. And then if we are to go for cardiac pacing, I think previously we discussed, and I will show this video. So as you said, so all the modern defibrillators are having this pacer mode. It will prompt into a pacer mode with a display. You can select the energy and the heart rate. You can select demand mode as well as fixed mode. You can select the heart rate as well as the output. If you are going for high output, please make sure it can be painful, so you need to sedate the patient and give some at least painkiller like fentanyl, because otherwise it will be painful. And you can increase the output until you see the capture beats. Right. And the last slide. Yeah, this is bread and butter. You all know how to use cardiac monitor, multi-para monitor, but I am going to give you a couple of tips. Whenever you are using pulse oximetry, use not the thumb, but the index finger, right? Index finger, that is the most, it is the contour and everything is designed for index finger, not for the thumb. And this wire should be placing the nail, not the other way around. Then only it works perfectly. And whenever you are seeing a saturation number, if you don't see that waveform, that saturation number is not reliable. Sometimes some cardiac monitors work without when they're hanging, right? Without even putting to a finger. So that is, but it doesn't give a waveform. You need to have that waveform. And if you don't get that waveform, patient with very hypothermic and vasoconstricted, cold peripheries, don't try to squeeze this thing. And don't try to put plasters or rubber band, because it will further compromise the venous, the micro circulation, right? This is the things that are usually done. So don't squeeze it. Just try to see the blood pressure and improve the blood pressure. You can warm the patient's peripheries with some warm blankets or keeping something like warm water-filled gloves. Otherwise, don't keep on pressing. And any number below 90 is just a calculated value, not the real saturation of the patient. If any number below 90, try not to work out with the pulse oximetry. Try to improve the patient's oxygenation. If the patient is on face mask, try to convert to CPAP. If they are breathing, check the breathing, or go back to ABCD. Don't waste time with the pulse oximetry. Then, if when you're using this cuff, correct size is very important. Smaller size cuff give a higher value. Bigger size cuff will give a smaller value for the blood pressure. Any ventilated patient on CPAP, please use this waveform capnography. You can see that the corner. This waveform capnography is very important for ventilated and intubated patient, because if you don't see this, there's very high risk the tube is esophageal or it might have come out. Right. Thank you very much for the time and all. And please ask questions during your discussion time. I know you have many questions, but please feel free to ask questions. Thank you very much. Thanks.
Thank you, Anup, for very much practical lecture. We will move to the next plenary.